Okay. Okay. My name is I'm a graduate of Sindh Medical College. I'm a general pediatrician. I'm diplomat American Board of Pediatrics, and I'm working in United States. It's a pleasure for me to teach you about asthma in children, a very common condition. Asthma is a very common chronic disease of children. It significantly impairs their quality of life. It scares their family members and causes financial burden. It also decreases child's self-esteem because they cannot play like other kids. So if it is not managed appropriately, it can kill the child. So definition of asthma is a disease of airways with inflammation, constriction of airway smooth muscles, mucus production, and edema that leads to obstruction and air trapping. Know that asthma is not a singular disease. It's just like a symptom, okay? And it's a symptom complex, and it has a very variety of presentations, a variety of different clinical phenotypes, as we call it, which can present as an acute condition. It can also present as a chronic condition on a long-term basis, and it can also have like an acute on chronic pattern. Like a child is coughing and wheezing on a daily basis, and one day he starts difficulty in breathing, and his parents have to take him to the hospital. So the clinical symptoms of asthma are cough, wheezing, chest tightness, prolonged exhalation, or shortness of breath. So I'm going to try to teach you today how to diagnose asthma in children and how you can differentiate it from other conditions which also make children cough and wheezing. Cough is such a common symptom. You can have coughing with just a common cold. And then we are going to talk about how to assess asthma severity and how do we control it and how we come up with an asthma action plan. It is something which you can give to family, and you can teach them how to use it to save their child's life. And then we'll talk about common asthma medications, how they work, and their adverse side effects. So let's start with this 2-year-old, healthy. He presents with a clear runny nose and dry cough for a week. He had a low-grade intermittent fever during first 2 days of illness, but the fever went away. So no fever for last 3-4 days. He's eating and drinking well. He's active and playful like his usual baseline. On physical examination, he appears well and comfortable. He has normal temperature, heart rate, and respirations. Exam shows clear nasal discharge. Both tympanic membranes are normal. Throat has mild redness with some postnasal drip. Tonsils are not enlarged. Chest exam shows no intercostal or supraesternal retractions. Lungs have good and equal air exchange bilaterally with few wheezes and rhonchi, diffusely scattered bilaterally. No rels or crackles. Rest of the exam is normal. Now, for students, wheezing are musical sounds, and rels are more watery sounds. So when you have secretions in the airway, you hear rels or crackles. So start thinking about the diagnosis. The way to become a doctor is that you look at the real patient and you start thinking what you have to do for it. And then whatever you are learning in your medical college, you bring it together to come up with a diagnosis. So just look at this style for just look at this slide for a minute and see what this child has. I will let you know in a minute. Okay. This kid has acute bronchiolitis. It's a viral illness which causes inflammation and edema of lower, smaller airways. It's most commonly caused by a virus which is called as RSV or respiratory syncytial virus. Other viruses are adenovirus, influenza, and parainfluenza. So think about how you are going to treat him. Lots of options. You can give him a cough syrup, you can give him albuterol, you can give him nebulizer treatment, you can give him an inhaler, you can give him steroids, lot of stuff. So think for a minute what you would like to do, and then we'll find out. So also keep thinking whatever you have done, if it is going to help the kid and how long this child is going to get better. The way I'm teaching you to think how a patient presents and use your knowledge to treat your patient in a very good way. So what we do for this child is that at that time you can just give some supportive treatment to this. You don't have to give him a cough syrup because he's too young. We try to avoid it because it can have effect on a child's heart. And that's it. And most children will get better in about 2 to 3 weeks. And they usually don't get into much trouble with it. So following this child all along, now this child is 2.5 years old. He presents with a clear runny nose and dry cough for 3 days. He woke up coughing and wheezing last night. He has low-grade intermittent fever, which resolves with acetaminophen. He is eating and drinking well. Actually, when he was seen by his doctor last time, he also got an inhaler. It is your asthma pump, as people commonly call it. So last time she felt that when she gave it to him, it did help him. So she gave it to him some, and it did help a little bit, but it didn't help that much. So now when you go ahead and examine this kid, it's normal except some clear runny nose and mild diffuse expiratory wheezing bilaterally. So think what your diagnosis is now. This is the second time in his life that he is getting these same symptoms. So your options are, again, bronchitis, bronchiolitis, whether it is an asthma, whether he has pneumonia or a reactive airway disease. This child has reactive airway disease or recurrent wheezing now. It is a diagnosis which is given to a child with multiple episodes of wheezing. He's perfectly healthy between these episodes. So that's why people get confused. In between, these kids are perfectly fine, back to their normal. But some episodes of wheezing and coughing can be really bad, and child can have trouble breathing, and he has to be admitted to the hospital. So now you start thinking, when are you going to call it asthma? Know that viral respiratory infections, which are called as common colds, there are major triggers of asthma in many patients. That's why most children and adults will get their asthma attacks in winter months. Infants with symptomatic bronchiolitis due to RSV or rhinovirus, they can have recurrent wheezing in first 5 years of life. So now the challenge is that there is no test. It's not that you can send him for an X-ray or you can test him for a blood test or whatever, and you will diagnose asthma. No, there is no test to do it. So you have to look at the symptom pattern. So symptoms of coughing and wheezing can be due to allergies or viruses. And when they did epidemiological studies of asthma, they found that wheezing is a very common symptom in preschool children. And most of these children are not going to develop chronic persistent asthma, which people also say that they outgrow their baby asthma. You can call it baby asthma. A lot of people actually call it baby asthma. So the complexity of asthma is that it is an immune mediated. You are prone to it based on your genes, which means if your mom or dad has asthma, or your brother or sister has it, chances are high. It has to do with your environment as well. If it's winter or if you're exposed to a lot of things that irritate your lungs, it can happen. So predicting asthma in young frequent wheezers, these are the kids who come to clinics every 2 to 3 months and they're wheezing. They're less than 3 years of age, and if they have more than 3 episodes of wheezing per year, then we will diagnose them with asthma if, okay, the major criteria will be if mom or dad has asthma or if a baby or child has eczema, because all these diseases are allergy mediated, so they're all interrelated. Minor criteria is allergic rhinitis, where people sneeze if they are around, maybe if they walk by a lawn and the grass was just mowed, or if they were around a cat and they were just playing with the cat in their home and they start sneezing. These are the symptoms of allergic rhinitis, that you're allergic to either cat or grass and you're sneezing. And if you don't have a cold, you just wake up in this morning and you start wheezing, you don't have any runny nose. And you can do a blood test if you want. You can do a CBC and you will find that eosinophils are elevated more than 4%. So other features are which our patient had. His doctor at one point prescribed him albuterol inhaler, or asthma pump as people would call it. And it's a short-acting beta agonist, and it helped him. So if it helps them in 1 to 2 days, or if sometimes if they're having trouble breathing and they are treated with oral steroids and they get better, they may have asthma. So now he's growing. Let's talk about this kid as he's 3.5 years old, right? Now, what I just went over with you, remember it was about the kids who are 3 and older. So now he's brought to the hospital this time with moderate to severe difficulty in breathing. He went to his aunt's and uncle's home. He was perfectly fine. He was just playing with their cat. It was first time when his parents allowed him to play with this cat. He developed nasal congestion and he was sneezing frequently when he left their home. And few hours later, he started to cough and wheeze and gradually developed difficulty in breathing. He was so bad that when he was taken to the emergency room, he needed oxygen and he had to be admitted to pediatrics. Parents report that he's also allergic to peanuts. So when he eats peanuts, he can get wheezing. And he has been wheezing like every other month over last 6 months, which does get better with albuterol inhaler. He also coughs when he runs and play with his friends in their lawn, and he wakes up many times at night coughing and wheezing. His father has asthma and mother has eczema. So there is a family history, right? So now we can diagnose this child with asthma, okay, based on our criteria, which we just discussed. And let's try to think what happened to this kid this time, because this was fairly life-threatening. He can die with it. So when airways of patients with asthma are exposed to environmental triggers, they respond with exaggerated bronchoconstriction, a phenomena which is commonly described as airway or bronchial hyperresponsiveness. And then there is a late phase asthmatic response to the allergen, and it also happens with viral respiratory infections. So the response pattern to an IgE-mediated allergy challenge is very, very important clinically because it causes an immediate obstruction and it resolves in about 4 to 12 hours. But then that airway obstruction happens again. So it's a late phase response. So back to him. And as we were already guessing, based on what we just discussed so far, is that he has asthma. So yes, he has asthma. And now we have to figure out what is the severity of his asthma and what are his risk factors. So what you do is, I'm going to go over with this diagram with you. You first make a diagnosis, then you figure out how severe how severe asthma is, and then you look at the triggers. Then you start medication and you teach parents how to use these inhalers correctly. I have seen a lot of kids who will just spray in their mouth and food, and they will kind of blow away all the medicine. No, they have to close their mouth, they have to hold it. So the technique has to be learned very correctly. And then you want to make sure the triggers are gone. Like he should not go to his uncle's house again, and he should not play with cat. He should be really kept away from it. So then you have to kind of ask parents and figure out how much they understood all that. So common triggers: viral respiratory infections, exercise. So when he runs and plays with his friends in the lawn, he can start coughing and wheezing, and that's a very common thing which you see in children. Weather changes, when especially it's very cold, exposure to tobacco, smoke, or even if something is burning somewhere, any kind of smoke can do that. Air pollution and smog, cold or hot air, strong perfumes. A lot of kids will actually respond to a very strong perfume and start wheezing. So 3.5-year-old's parents are now extremely worried. They thought he was going to die and they do not want it to happen again. And they're willing to do whatever you are going to tell him. So let's figure out how we are going to treat him. We are going to treat him with beta agonist, which is albuterol, which is your short acting, which works on the receptors on airway smooth muscles, and it triggers a cascade which leads to relaxation of airway muscles and improved airflow. They are divided by their pharmacologic characteristics into short-acting beta agonists and long-acting beta agonists, SABA or LABA as we call them. So SABA, which is your albuterol, most of you are familiar with it. It works within 15 minutes, but it wears off in 3 to 4 hours. LABA, as salmeterol, can last up to 12 hours, but it cannot be given to children because they can die with it. So we do not use it in children. It's only used in adults. Adverse effects: tremors. The child might not sleep through the night. It can also cause tachycardia. And it's very important to figure out how much beta-2 agonists are used, because if they're using it too frequently, they're using it like every 2-3 days, their asthma is not controlled. They need more medicines, they need different medicines, and when they use it quite frequently, the chances of the child dying with asthma is very high. So asthma is classified as intermittent, mild, moderate, and severe. And this is called as impairment, which means that child is impaired in breathing in this way. Risk factor, it refers to history of asthma, and it kind of figures out how quickly you get bad. Like some people will not get bad like this kid, so their risk is low, but this child's risk is very high. So assessment of risk is very important. Like, I don't care if he didn't wheeze for 6 months, but if he was admitted to the hospital like this, he should be treated with more medicines in addition to albuterol. So goals of asthma therapy is to improve quality of life. Childhood is all about running and playing. He should be able to play with his kid friends without any trouble breathing. And his symptoms should be controlled well. He should not be coughing, wheezing, waking up at night, and his use for albuterol or beta-2 agonists should be very low, and he should be able to play whatever he wants. We don't have to keep him closed indoors at all. He should not go to emergency department or hospital again and again to get admitted, and he should not have bad asthma attacks, and side effect of medication should not be very high either. So assessment of asthma severity is initial assessment should be done before you start some long-term control medicine. And this child, because he was about to die, he's definitely needs long-term control medicines. So now we are going to talk about long-term control medicines based on the guidelines. So there are two main areas, which I already explained it to you, the impairment and the future risk. So this is a very short reference guide. It is in your textbooks of pediatrics, so you can look at it. Basically, it tells you how asthma is classified. It's based on the year. So if you get your symptoms less than 2 days a week, it's intermittent. If you wake up less frequently than 2 times a month, it's intermittent. If you just use your albuterol 2 times a week, then it's intermittent. If it does not interfere with your life, you can run, play, do whatever, it is intermittent. Now the lower part, which is actually with the pulmonary function test, where you have to blow into things, is still less than 2 times the week, but they're not every day. So simple way of explaining this, that the child is coughing and wheezing 3 or 4 times a week. And then he wakes up 3 to 4 times a month with coughing and wheezing. He uses his albuterol 2 to 3 times a week, and he cannot run and play very well with his friends. He gets short of breath and he has to stop. The persistent one is the one who has symptoms every day, okay? And the ones who are severe are the one which are without symptoms rarely. So this is how it's classified. So you classify the symptoms and then you start treatment. So again, when you are looking at the age, what you try to do is that you start treating them with medication. So the medications are given stepwise. So first, you start them, as we already talked about, intermittent albuterol use. But if they are becoming like mild persistent or moderate persistent, then you go ahead and put them on inhaled corticosteroids twice a day, and you can use any inhaled steroids which are available. Flovent and QR are quite frequently used. And then if they don't get better with it, you can go up on the dose. And so this is actually very important. You also see what triggers it. So for example, if they are allergic to dust, what you're going to do with dust is going to be dusty all the time, then you need to put them on some allergy medicine like Claritin or Zyrtec, loratadine, or cetirizine. So again, it's kind of telling you what I just told you. And in children, when you are going to go to the next step, you can also go ahead and put them on Singular, which is another medicine which controls the symptoms in children and is something which children can take. So the inhaled corticosteroids, which we talked about, or leukotriene inhibitors, they are your second step of treatment. Now, Singular is very good, which is your Montelukast, and is used for both allergies as well as asthma. Fluticasone or Flovent is commonly used. QR is your beclomethasone. And oral steroids can be used for 5 days if they are having trouble breathing or if they're getting bad. So oral steroids, they are should be considered frequently if they are getting bad, because they improve the underlying inflammation right away. And it also makes child more responsive to albuterol. And it really, really helps to open up those lungs and decrease the swelling inside the lungs. So we already went over the guidelines with it. So you are going to put them on medicines stepwise. You are going to give them more medicines if they are having more symptoms, and you will go down. So same child, if he gets better after, like, let's say a couple of months, you can decrease his doses accordingly. And you also have to go over these environmental controls as we talked about. Now, usually it's important that once you have decided to treat them with a particular kind of medicines, treat them for at least 3 months. So don't hurry in stopping the medicine. If you have to stop the medicine, you have to give it at least 3 months. So all the inflammation in the lungs, which is causing bronchospasm, should be completely cleared. So goals are long-term control, and to make sure you have least side effects. And then you want to maintain a good lung function. Now, when I was a medical student, asthma meant the kids were locked in the home. They are not going to do much. They can never run and play. And by the time they got older, their lungs were pretty damaged. They, as an adults, they had lot of lung damage. But now, these kids were treated this way as teenagers. If they want to play football, hockey, cricket, run, do whatever they want. So sky's the limit. Their lungs are healthy. So this treatment keeps them healthy. Now, control of future disease risk is very important, as we talked about. And if you're going to keep the lungs healthy, the risk will go down. How frequently you should see? They should be seen every 2 weeks or 2 months based on how they are doing. And then even when they get better, I said you should see them at least 1 to 3 months. Now, this is something which is called as an asthma action plan. This is something which doctor can write with uh, parents and child, and it tells them what to do. So they can start treatment at home if the symptoms are getting worse. And it's important to give a copy of this plan to parents as well as to school or any family members, grandparents, aunts and uncle, whoever is taking care of the child. This is also a picture version of it. So whatever was written there now is picture, so it's easy to see, especially for the people who cannot read and write. They can look at the pictures and they know which medicine can be given when. And so there are different versions of it. This one is something which is by American Lung Association. So this is what I wanted to share with you about asthma in children. And if you have any questions, comments, feel free to let me know. Have a good day. Thank you.